Chicken pox. Skin lesion of chicken pox has few stages: papules, papules or rare skin lesions, then superficial vesicles filled with clear fluid on an erythematous base. This appearance is called dewdrop on rose petal, then umbilicated and crusted pustules. Overview: Chickenpox, that is varicella, is an infection caused by the varicella zoster virus. The condition predominantly affects children. Transmission occurs via inhalation of airborne droplets and direct contact with respiratory secretions or skin lesion fluids. Chickenpox manifests with an intensely pruritic rash characterized by sequential clusters of papules, vesicles, and pustules in various stages of development. The rash may be preceded by a prodrome of constitutional symptoms. A clinical diagnosis is made based on the appearance of the rash. Confirmatory testing may be obtained for atypical rashes or severe infection. In immunocompetent individuals, chickenpox is self-limiting and managed symptomatically. Antiviral therapy is reserved for patients with severe infection or at high risk for complications, for example, bacterial superinfection, invasive infections. Following resolution, the virus remains latent in the sensory nerve root ganglia. It can reactivate as shingles during episodes of stress or immunosuppression. Prevention includes routine vaccination and, when indicated, post-exposure prophylaxis. Epidemiology: Chickenpox primarily occurs in children. Before vaccines were widely introduced, 90% of all children had been infected by the age of 15. Etiology: Pathogen causing chickenpox is varicella zoster virus, a human herpes virus type 3. Transmission is through airborne droplets, direct skin contact with varicella zoster virus infected vesical fluid, and transplacental. Infectivity: Chickenpox is highly contagious. 2 days before and up to 5 days after the onset of exanthem or until all the lesions have formed crust. Latency: It can become latent after primary infection and reside inside the trigeminal and/or dorsal root ganglia. Clinical features of chickenpox: incubation period 2 weeks, range is 10 to 21 days. Prodrome phase: Prodrome phase is rare in children. Prodrome phase contains constitutional symptoms, for example fever, malaise, headache, muscle or joint pain, 2 to 3 days prior to the onset of exanthem. Exanthem phase: Exanthem phase is characterized by approximately 250 to 500 severely pruritic lesions in varying stages of development. Lesion stages: papules, superficial vesicles filled with clear fluid on an erythematous base, dewdrop on rose petal appearance, then umbilicated and crusted pustules. Scabs fall off after 1 to 3 weeks, often leaving a depressed base. These are the stages of lesion caused by chickenpox. Skin involvement: Lesions first manifest centrally, that is face, scalp, and trunk, and spread to the extremities. The rash is ultimately distributed across the body, with the highest concentration of lesions in the central areas. The oral and urogenital mucous membranes are affected. Ocular involvement may be present, varicella zoster virus conjunctivitis. Palms and soles are typically spared. Features of severe varicella infection may develop, for example, prolonged high fever, more than 1 week, prolonged eruption of vesicles, more than 5 days, signs of thrombocytopenia, including hemorrhagic skin lesions, symptoms of visceral dissemination, for example, encephalitis, pneumonia. Latent phase: Following resolution of active skin infection, varicella zoster virus remains latent in the sensory root ganglia. It can later reactivate as shingles. Severe varicella infection is characterized by the prolonged eruption of vesicles, which are sometimes hemorrhagic, high fever, more than 1 week duration, and dissemination of varicella zoster virus to the brain, encephalitis, liver hepatitis, and or lungs pneumonia. Chickenpox: A vesicle filled with clear fluid on an erythematous base is seen on the skin of this patient. This appearance is referred to as a dewdrop on a rose petal. and in combination with other skin lesions indicates infection with varicella zoster virus, chickenpox. A diffuse rash is seen in various stages of lesion evolution, starry sky appearance, with mainly ruptured vesicles and crusted erosion seen here. These findings are typical for chickenpox. Facial rash in chickenpox. The face of the girl shows macules. Macules are flat lesions, vesicles, and papules. Papules are raised skin lesions on an erythematous base, as well as erupted vesicles and crusted papules. The simultaneous occurrence of various stages of rash is sometimes described as starry sky and is typical of chickenpox. Exanthem of oral mucous membrane in chickenpox, a vesicle on an erythematous base located on the right side of the hard palate. Aphthae, two small aphthae are visible at the tip of the tongue and on the right side. Aphthae are non-specific; in this case they were associated with varicella infection. Upper body of a young boy with exanthem showing the simultaneous occurrence of various stages of rash, mainly vesicles and pustule, no crusted erosions. This clinical finding is also referred to as starry sky and is typical of chickenpox. Two papules and a vesicle are visible. The cloudy appearance of the vesicle fluid indicates that it is in the course of transitioning into a pustule. The development of a rash manifesting with various stages simultaneously is typical of chickenpox. Chest of a child, multiple vesicles filled with clear fluid on an erythematous base are visible. This clinical finding is called dew drops on a rose petal, and it is classically seen in varicella chickenpox. Multiple disseminated papules and vesicles on an erythematous base are visible on this patient's face. Numerous vesicles in the pre-auricular region appear umbilicated. These lesions are caused by an infection with varicella zoster virus. Risk factors for severe varicella zoster virus infection. Individuals with any of the following factors are at risk of severe primary infection if they have no evidence of varicella zoster virus immunity. Age more than 12 years, immunosuppression, pregnancy, chronic skin or lung disease, which may lead to bacterial superinfection on the skin, or pneumonia in case of chronic lung disease. Long-term salicylate therapy, for example aspirin. Aspirin can lead to Reye syndrome in children. Infancy. Less than 28 years of age. Premature infants during their initial hospitalization with any of the following: born at less than 28 weeks gestation, birth weight less than 1 kg, born at more than 28 weeks to a non-immune mother. Household exposure. Household exposure is more severe or lethal than community exposure. These are the risk factors for severe varicella zoster virus or chickenpox virus infection. Diagnostics. Typically diagnosed clinically based on characteristic clinical features. Confirmatory studies, PCR, preferred test for active infection, detects varicella zoster virus DNA, direct fluorescent antibody testing on vesicular fluid, serology, IgM and IgG detection can identify primary infection and serologic immunity. Viral culture. Viral culture takes 3 to 10 days and it is also low yield. Zinc smear, not specific for varicella zoster virus, may also be positive in herpes simplex virus infections. Usually chickenpox is diagnosed clinically. PCR can be done to confirm it. Other tests are usually not done. Chickenpox is usually diagnosed clinically or plain lab testing in case of atypical rash or severe infections. Supportive treatment. Treat fever and pain with acetaminophen. Children less than 12 years, acetaminophen 10 to 15 mg per kg every 6 hours. Max daily dose 75 mg per kg per 24 hours. Total dose should not exceed 3750 mg. Adults and children greater than 12 years, acetaminophen 3 to 5 to 1000 mg every 6 hours. Max daily dose 4000 mg. Treat fever and pain with acetaminophen. You can copy doses. Pruritus. For pruritus, general advice for caregivers: apply cool compresses, take lukewarm oatmeal baths, trim fingernails or wear mitts to prevent scratching. Medications for pruritus: topical calamine lotion, pramoxine gel, oral antihistamines. Avoid topical antihistamines and topical corticosteroids in patients with chickenpox because of the risk of systemic absorption when applied to large areas of skin. NSAIDs should be avoided. Aspirin is associated with Reye syndrome, and ibuprofen may be associated with invasive group A strep in patients with varicella. Antiviral therapy for varicella zoster virus infection, high-risk patients only. Indications for antiviral therapy: severe varicella zoster virus infection, risk factors for severe varicella zoster virus infection. Assess for indications for antiviral therapy for varicella. If present, determine duration of symptoms. Symptom duration less than 72 hours. Initiate immediate antiviral therapy. Antivirals are only effective during varicella zoster virus replication, which lasts up to 72 hours in immunocompetent hosts. Symptom duration greater than 72 hours. Consult with infectious diseases specialist. Antiviral therapy may be appropriate in immunocompromised patients because of prolonged viral replication. Recommended treatment: begin antiviral therapy as soon as possible, ideally within 24 hours of rash onset. If antiviral therapy is indicated, do not wait for lab tests. Immunocompromised individuals, neonates, and those with severe infection, IV acyclovir, those you can copy by pausing the video. Immunocompetent individuals, individuals with non-severe infection, oral acyclovir or valcyclovir, those you can copy by pausing the video. Patients with non-severe infections and no risk factor for severe varicella zoster virus infection do not require antiviral therapy and can be managed with supportive treatment only. Neonates, immunocompromised patients, and patients with severe infection should not receive oral acyclovir because of poor oral bioavailability. Complications: bacterial superinfection, shingles, scarring, acute cerebellar ataxia. Good prognosis, mainly self-limiting after several weeks. Encephalitis, very rare. Cramps, coma, poor prognosis. Pneumonia, viral or bacterial. Pneumonia is the most common complication if chickenpox occurs in pregnancy. Congenital varicella syndrome can occur in newborn fetus. Prognosis: in healthy children, chickenpox infection generally has a benign course and heals without any consequences. Residual scarring may occur because of excessive scratching or bacterial superinfection. Immunosuppressed individuals are at a greater risk of the disease taking a generalized or even fatal course. Prevention: ensure children receive varicella vaccination as part of the routine immunization schedule. Tell patients to avoid school or work until all lesions have scabbed over and no new lesions appear. Typically takes at least 5 days. Active immunization consists of 2 doses of a live attenuated vaccine. Available vaccines include a single antigen varicella vaccine, a combined measles, mumps, rubella varicella vaccine. Passive immunization: preferred varicella zoster immune globulin, individuals less than 40 kg, dosage based on weight 1 to 5 mg per 10 kg, max 6 to 5 mg per kg. Individuals greater or equal to 40 kg, varicella zoster immunoglobulin 6 to 5 units intramuscular once. If varicella zoster immunoglobulin is unavailable within 10 days post-exposure, intravenous immunoglobulin 400 mg per kg IV once. Thank you.